Hello, my name is Niall McKay and welcome to Living with PSC, a podcast about the rare disease of primary sclerosing cholangitis. Now, PSC causes the bile ducts inside and outside the liver to become scarred, narrowed and eventually blocked, and leads to liver cirrhosis. In this podcast, we aim to dispel some of the myths about the disease. Welcome, Julie Heimbach. Today, Julie is the Professor of Surgery and the Chair of the Division of Transplant Surgery at the Mayo Clinic in Rochester, Minnesota. Welcome, Julie.
Thank you very much, Neil. I'm delighted to be here with you.
We're delighted to talk to you again. We talked to you a little, I think about a year ago at this stage, so it's great to have you back on the show. If you are lucky enough to be sick enough to be listed for a transplant, it's sort of a what then? What are the things one should consider at that point?
Neil, the most important thing, of course, would be to be sure that you've been evaluated at a transplant center. Some patients with PSC are being cared for by medical specialists who are not at a transplant center. So if your disease is progressing, then it would be really important to be sure that you've been seen at a transplant center, because if you're not at a transplant center, then of course you're not going to be on a transplant list. So that's the first thing. When you are seen at your transplant center, then it's just important to be sure that you feel like you've had a good connection with the team that you've met at the transplant center. And I think that's important.
And what are the things, is there a long list in the United States? How does, what happens once you get listed?
Yeah, that's a great question, Neil. Unfortunately, that's, one of the main barriers for patients with cirrhosis from any cause really is that they have a disease that can be treated with transplant. In fact, it is very well treated by transplant. We have excellent outcomes following transplant with an anticipated survival benefit, but we cannot provide this therapy to every patient who needs it. In the ideal world, we would be able to transplant patients at the exact time where their disease would warrant it, so that we don't do it when it's too soon, but we wouldn't make people continue to suffer and wait. Ideally, we could apply this therapy at the exact time that it was appropriate for the patient, but unfortunately, that is not possible. There are not enough donor livers available for that to happen. We do have the option of living donor transplant, which is a really important option, I think, for especially for patients with PSC to explore, as it does provide an opportunity for transplant for patients who are waiting and continuing to suffer and having complications, but not having a priority score that allows them a good chance to have a transplant from a deceased donor. But even with the consideration of living donor, not everybody has, someone that could donate for them. So that still leaves a lot of patients who are waiting, and that's really difficult. It's very difficult for patients because they're waiting and they don't exactly know how long they're going to be waiting, and so they're running a marathon, but they don't know how long the race is, and that's very hard.
And what are the things they should be doing during that time?
Well, that's a good question. The parts that are within the control of the patient to some degree are just trying to do everything they can to, can help, which is, try to remain active, physically active. You have a disease that makes people feel extremely exhausted and tired. And so the tendency is to obviously not to be active. But, patients do suffer from significant muscle wasting. That means loss of muscle mass. And, as they feel increasingly fatigued, they tend to become less active, which then further reduces their muscle mass. And, weakness can be a significant problem. And then also nutrition, making sure that they are able to work with a nutritionist to make sure that they're getting adequate protein and nutrition. Those are two things that patients who are waiting can do. Make sure that you are following with your transplant center so that you're having the screening that you need to have while you're on the wait list to make sure additional complications like varices, which are big swollen blood vessels that can happen in the lining of the throat, or tumors that can happen in the liver, we would continue to watch for those. Patients are typically screened every 6 months while they're, once they have cirrhosis. That would be something we would need to do. So those are really important things to do.
So that's particularly regular MRIs and CT scans and stuff like that.
And ultrasound, depending on the type of screening. PSC patients, sometimes we want to do additional screening for bile duct cancer, and that would depend on the patient's condition. But the method of screening, is not as clearly established as the method of screening for another kind of cancer, which is hepatocellular cancer, much more common actually, and that would be typically done with ultrasound, but sometimes we also need to use MR or CT scan.
And in terms of because the nutrition is tricky, right? Because PSC patients typically have a limited diet because they can't digest fats. So that often means meats, so what do you advise your patients, or how do they keep their strength up?
Yeah, that is so important. And many times patients experience a feeling of fullness just because the liver can be large, or, sometimes they can have fluid in their abdomen from their liver disease. That can also make them full, and it can make them difficult to eat. So having many frequent small meals can sometimes counteract that. So rather than the typical 3 meals a day, have, more frequent meals with a smaller volume, so that feeling of fullness is not a barrier. Other strategies are to think about taking a supplement like a liquid, like Boost, or those kinds of Ensure drinks, supplement drinks that have a good amount of protein and other nutrients in them in a small volume. So again, if food, especially meats, as you've mentioned, are not easy to digest or not appealing, you can think about getting protein and calories from a supplement, because that's a small volume to take, but it does have a concentrated amount of nutrients within it. So that's another strategy that can be useful. But certainly, at every transplant center, you should be able to visit with a dietitian who's quite expert in this and can really help with this, making sure that the patient is able to the best of their ability, maintain their nutrition.
And then I believe when somebody is on a list, that there are further decisions to be made. So specifically, whether or not they should take a Hep C or a Hep B liver, whether the donor has ever had any type of cancer, including skin cancer. What can you talk a little bit about that process?
Yeah, that's a really critical discussion as well. And I personally find that the ideal time to have that discussion is actually when you're first, getting on the transplant list, rather than say, at midnight in the middle of the night when the, transplant center is calling you with the organ offer. You want to have understood what these different things mean, well in advance, so that it's just easier to think about them. I really would say that, in most cases, if the transplant center is calling you to offer you an organ, that it's typically in your best interest to accept it. And if you don't feel that connection to your transplant center, then that would, be a concern. I think that you should feel confident in your transplant center that they're not going to call you and offer you something that is not in your best interest. But besides that, I also think it's critical to talk through these various types of donor offers so that you are having a clear understanding of what that means. One in particular that always gets people's attention, because they actually at the current time are required to sign a form to say they understand that they're having this type of liver, and that's a increased risk, or PHS, public health system increased risk donor. What that means, or what that refers to, is the risk of disease transmission from the donor to the recipient. And typically this is referring to the bloodstream viral infections that could be transmitted, specifically the virus hepatitis C, as you mentioned, or hepatitis B, which is another bloodstream virus that actually causes liver disease, or HIV, which is a bloodstream virus that causes AIDS, which is a viral transmitted immune system disease. So these different viruses, we actually are already testing all of the deceased donors, actually, and living donors too, for these viruses, and and so we try to identify them. The issue is that the test could be negative, but the donor could still have the disease. And so then if there is any kind of exposure or behavior from the donor that would say, well, maybe there's an increased chance that they could have acquired it, then they would be classified as increased risk. But the reality is that the risk is so tiny that even an increased risk donor is definitely better than no donor at all. And it is so common to be classified as increased risk. In fact, almost 30% of the organs that we use are classified as increased risk. And the risk is still far less than 1% that there would actually be an unknown disease transmission. And in fact, the reality is for hepatitis C positive donors, we actually now use these intentionally. So even when we've identified hepatitis C, we would actually still offer it to almost every patient on our waiting list, because as long as that donor liver is a healthy liver, which we would typically biopsy it to make sure it was healthy and it didn't suffer any damage from that hepatitis C infection. Because when someone has a hepatitis C infection, sometimes they don't get any liver damage, or it takes many, many years to have liver damage. We've used hepatitis C positive liver donors for a long time, but we've targeted it to our hepatitis C positive recipients. But now that there's been a very, very effective treatment for hepatitis C, we actually don't have any hepatitis C recipients left to give these livers to. So now we're using them for our hepatitis C negative patients, because we know that the virus is so easy to treat now that it would not make any sense not to use these very, very good livers, because it's a treatable infection. Similarly, for hepatitis B, if the donor has been exposed to hepatitis B in the past and they're not having an active hepatitis B infection, it's called a hepatitis B core antibody positive, that would show up as a long time ago or at some period of time they had been exposed. Those also we have a medication that the recipient of that liver could take that could prevent hepatitis B from ever becoming a problem. And there's also a vaccination for hepatitis B, so that would reduce the risk even further if the recipient had gotten the vaccine, or if we give them the vaccine even after they've been transplanted. So these are all options. So hepatitis B core positive antibody is a very straightforward decision. I think it would be one that I would recommend to any of my patients to accept. And really any increased risk donor, I would accept that for myself or for anybody in my family. And there's, I think, not a reason, considering the risk, to decline that offer, considering especially the risk of waitlist mortality for everybody on the list, which is about 20%, compared to that much less than 1% chance of actually getting an infection.
I see. Yeah. So and maybe there's a different system in Europe these days, but there are other. They say would one of the questions is a liver after circulatory death.
Yeah, so that's a different kind of donor, a DCD, or donation after circulatory death, and that's a really, I think, a harder question for patients with PSC. The problem with a donation after circulatory death liver is that, number one problem is it doesn't always proceed. So the recipient or the potential recipient would come into the transplant center for the possible transplant. The transplant team would go out for the organ recovery, and we would not be able to proceed because the potential donor, what happens is they're actually not brain dead, not meeting the brain death criteria, even though they've had a devastating injury. Then their family has still agreed they want their loved one to be an organ donor, and they've already made a decision to withdraw the life-sustaining treatment. So that, say the ventilator and other supporting measures are withdrawn typically in the operating room, and then there's a period of time where there's an observation and waiting for the patient's heart to stop. So that would be circulatory death. They are then declared dead, and then we can proceed with organ recovery. In that situation, sometimes it just takes too long for that heart to stop, and so then it is not safe to proceed with organ recovery after that long period of time. So that's one problem, that it doesn't always go forward, and especially if the recipient has to travel from a long ways away. That can be quite difficult. The other issue is even if it goes forward, everything works perfectly. The liver looks great. The transplant goes great. There is a chance of an injury called ischemic cholangiopathy. This is a scarring process that happens inside the liver in the bile ducts, actually. And if you look at it on the pictures, it looks a lot like PSC. We don't fully understand why this happens, but it does appear to be related to that period of time where we're waiting for the heart to stop, where the liver's not getting good blood supply, not getting good amount of oxygen, and the bile ducts can get injured. And so, what does it mean to give this type of liver to someone with PSC? Would they have more chance that this problem could happen? And in fact, there is some suggestion in the data that that is true. So it's not totally clear what a patient with PSC should do for this specific type of liver of donation after circulatory death. But our center, we're using these livers for PSC patients. We've seen that the risk seems to be higher, and we've stopped using them. And there's literature to suggest that that is observed at other centers. So I think if someone is going to accept that, they just need to be in the right situation. If they're very, very sick and there's no other good option, it's definitely the right thing to do. In other circumstances, we would just have to just realize that there may be a slightly increased risk for patients with PSC. We really just don't know yet.
I understand. And then a liver from a person who has had some sort of history with cancer, probably a very small one, but...
Yeah, I think in general, you'd have to understand what is the prior cancer, but in most cases, a history of prior cancer is not something that we would, be particularly worried about. If we were really worried, we wouldn't typically offer it to anyone. So I don't think we should ever ask patients to make decisions when they don't have all the same amount of information that the transplant team knows and understands. So if somebody, just died with a colon cancer that had already spread, we wouldn't be offering those organs out to anybody because we know it's a very, very high risk. But if somebody had 10 years ago, they had a small breast cancer or skin cancer, we wouldn't think twice about that particular type of donor, depending on, how extensive the disease was. But in most cases, if a donor has an extensive history of cancer, they're not eligible to be an organ donor.
I understand. And that's what we're doing here, is just to try and help people make those decisions because obviously, as you say, they make them because they make them at the time. Because if you're ringing them up, sort of saying, "We have a type 2 diabetes liver for you," you'd be like, "Yeah, I'll take it."
Yeah, I really think that. For understanding all these terms, it's really good you've heard them before the actual moment where you have to make the decision, and understand that in general, they're not going to call you and ask you to make what they think is a bad decision.
Of course, yeah.
They would have thought about it for you. They know where you are on the wait list, and I think that's really important.
Yeah. And then it is interesting that a circulatory death liver for a PSC patient, that's a very interesting point, because other people may not know that.
It's just uncertain at this time, and I think for certain patients who are really doing very badly on the list, this is a consideration. But I think it's definitely something we have to keep exploring and understanding, and whether using the perfusion machines that are starting to become available will influence that risk or not. These are uncertain things that are evolving.
And sorry, what's a perfusion machine?
So they're more being used actually more in Europe than in the United States, but they're under active study. After the liver is removed from the donor, they actually put them on a perfusion pump to try to reduce the chance of injury to the liver when it's transplanted, so that maybe reduce this problem of the bile duct damage or other problems that can happen. So maybe in the future, if we can use those for DCD livers, those would be less of a worry for patients with PSC. So that's evolving.
I see. It's a tricky area, so I appreciate your help with it. Is there other things that people will be asked to consider, or that you think they should consider? Questions they need to ask once they're on a list.
I think depending on the situation, certainly asking about the possibility of living donation is an important question, in my opinion, for patients with PSC.
I see. And do you want, so a living donation is where you,
whether the center is available, does have that capability or has an experience in that. There are complications of PSC, like, for example, itching, that can be so disabling for patients and so distressing, but not necessarily changing their, risk of death or their priority for transplant, but certainly could be relieved if we can proceed to transplant. And so, those are types of conditions, or, other things like the muscle wasting and the fatigue and the difficulties with encephalopathy, which is a confusion that can come with liver disease and make it really hard to concentrate and be effective, in your job or in your life, really. And so those conditions also would be reasons that we would want to go to transplant. And if your score is too low, then living donor is an option for that as
well. And I mean, this may be asking, and if it's not something you're comfortable with, but what causes the itching? Is that just a high level of bilirubin in the blood, a high level of bile in the blood?
Well, we don't know the cause of itching, but it certainly does appear to relate something to the cholestasis, or the sort of poor metabolism of bile. And so, there's a variety of different things we try to do to help with it, but we don't actually know 100% what the cause of it is.
Yeah, things like giving cholesterol or stuff like that.
Yeah, to sort of try to absorb some of the bile salts. I don't think we fully understand the cause.
Yeah. And then just moving on to the transplant itself, and we'll be quick on this. Typically, how long does a transplant operation last?
Well, the surgery itself, I would say roughly about 4 or 5 hours. And then typically the patients would be monitored in a setting like, either a step-down unit or a unit that would monitor them for a period of time. Sometimes it's a longer stay in the recovery area where they're on a monitor. Sometimes it's a stay in the intensive care unit. It just kind of depends on what's available at the hospital where the patient's having their transplant, and kind of how things went with the transplant. But after that monitored period, then they would typically go to the regular transplant unit, and then typically in the hospital for a period of time. And that would depend on how strong the patient is coming into the surgery and on how straightforward the recovery goes. But it could be just as short as, say 5 or 6 days if everything is going just perfect. And then it would be longer if, they have other issues, or if they're really quite weak. Sometimes even patients need to go into a place like an inpatient unit to just focus on getting stronger, or rehabilitation for a period of 1 to 2 weeks. That really depends on, again, how the patient is coming into the surgery.
So the more, for the want of a better expression, but the more you can kind of Rambo yourself up going into the operation, a lot better off you'll be during it.
Well, I would say rather than Rambo up, which is a great term, I love that, but I would say more of a maintain. So trying not to lose. I think that's one of the problems that I see patients can, if they're seeing that they're losing weight and seeing that it's becoming more difficult to walk a certain distance, you want to try to continue to focus on that and monitor your weight and make sure you're not losing more weight, and try to pick a specific amount of distance that you're going to walk each day, so that you try to hold on to that, using some resistance bands or other kind of things to keep maintaining muscle, rather that you're not really going to be effectively able to gain, but it's a matter of trying not to lose.
I understand. So is there anything I haven't asked that I should have asked you?
Well, I think this has been a really great discussion. And I would say, sometimes the recurrent PSC is a topic that comes up, and,
of course,
I don't have a great answer for that. I mean, it certainly does happen, something that we watch for. Importantly, that if someone does get recurrent PSC, it doesn't always mean that they're immediately going to have another transplant. Sometimes it can stay without any progression for a prolonged period of time. But sometimes patients even need to have a second transplant for recurrent PSC. But, that's something that can be done as well. So I think that it sounds like a very scary problem to someone facing their first transplant, wondering, well, is this just going to come right back? And for most patients, it doesn't come right back. And even if it does come back down the road, most of the time, it could be a long, progression after that return of disease. And, as everything goes on, I'm certainly remain very hopeful with all the research that's being done that we'll find a cure for PSC or a treatment for PSC that can be effective, similarly to the progress that has just been made for hepatitis C, which is so remarkable. I'm hopeful that we'll find that kind of treatment for PSC patients.
Yeah, because in a way it's sort of a sledgehammer to crack a nut, isn't it, in terms of it's a big operation for a disease that will hopefully be cured another way.
Well, ideally that would be true. Sometimes, patients don't even know they had it and they come in and they've already had cirrhosis. So there may always be patients that, we wouldn't even have known. But definitely there's a lot of work being done by a lot of really dedicated and very capable people. So I'm hopeful that the future will bring better treatments than we have today.
And finally, is there sort of a time that livers last? Is there a 15, 20 year, is there statistics on, you have 25 years?
Yeah, so that's a really good question, because we know, for example, in a kidney transplant where over time there does seem to be that the kidney can kind of, as you would say, wear out. But actually for the liver, there is no expiration date. It does continue to regenerate itself, which is actually why living donation is even possible, is because the liver actually, when you remove part of a healthy person's liver, they grow back the part that you took out right away. And the part that you give to the recipient grows to a whole size liver. So the fact that the liver can regenerate is probably why it can continue to last. And so that the liver itself does not appear to sort of wear out over time. We do, as I mentioned, have an issue sometimes with recurrent disease. The primary liver disease can return, but in short of that, the liver does not seem to wear out. And we can even use livers from older people and put them into younger people, and they continue to function and regenerate and kind of make themselves over again, which is really amazing.
It's an amazing organ, yeah. Well, I think that is everything. I'm so grateful that you took the time to talk to me, and thank you very much. I guess finally would be, is the coronavirus impacting you much at the moment?
Yeah, that has been a really challenging thing for really the whole healthcare system across the United States. And there was a period of time where we saw a significant decrease in organ donation. And, that was probably multifactorial, related to, people not coming to seek healthcare, and maybe not, the emergency rooms not being able to handle it, and people maybe not being out and about, so not suffering from sometimes even the accidents that can happen when you're out and about that can lead to head injuries and people needing, going on to becoming organ donors. So all of those factors probably contributed to the reduction. We saw a very significant reduction in organ donation for a period of time. That does not appear to be still the case. That appears to be coming back to more normal levels around the country. There was difficulty also in some cities where the COVID crisis was very severe, where you would not be able to proceed to transplant because the intensive care units were full and the hospitals were full with patients with infection, and you don't want to consider going forward to a transplant and being on medication to reduce your immune system in the setting of this uncontrolled infection. But that, I think we've learned so much more now about how to reduce the risk and, the appropriate quarantine steps and all of those things. So I think that it's getting much better now.
Great. Well, Professor Heimbach, I'm really grateful. Thank you so much for your time.
Absolutely. It was great to speak to you today. Thanks very much.
Well, I'm afraid that's all the time we have for this week. For more information about PSC and for a list of people and topics we'll be covering in the near future, please go to www.pscpartners.org. That's www.pscpartners.org. PSC Partners is a non-profit organisation dedicated to providing education and support to primary sclerosing cholangitis patients. There is information and resources on the website. There is a conference once a year. There is a private Facebook group that you can also join. Also, please join our patient registry. This is an anonymous database that provides research support to the medical community who are researching this disease. Thank you very much for listening.